Currently, there are a number of different medications made available, being provided by the US government with whatever COVID-related funding is still there, that is intended to stop you from developing severe cases of COVID. The issue is, for a number of different reasons that we're gonna dive into, the vast majority are not actually being used, even as case counts remain high and deaths remain tragically high. Well over 1,000 people still dying of COVID every day. There is medication literally going to waste on shelves, expiring, not being used for reasons we're gonna jump into. So initially, some treatments, really effective and also in some cases expensive treatments, like monoclonal antibodies, those supplies were tight, creating the perception that only the rich and the powerful had access. No, others had access, not necessarily the ability to afford it, but they were there. States, hospitals, and health providers ordered the treatment directly from manufacturers, which did stress the supply chain at that time. But back in September, the US government bought up all supplies and started to make it available based on case and usage counts in different states. But how is that actually going? When you look at different medications, you take a look at this chart. The dark green bar there is the percentage of the supply that's been made available to them that they're actually requesting. That's as high as 90% for some treatments, down to 50% on others. But the amount that have actually been used is even lower than that. In some cases, you're talking a couple percentage points of the available supply actually being used. And the highest you have there is at 40%. These are all treatments that, in a variety of different uses for people at different points in their tragic COVID journey, could make the disease not nearly as bad. Avoid stays in the hospital, avoid ventilators, avoid deaths. But a lot are just sitting in refrigerated storage or sitting on shelves, not being used for a variety of different reasons. We'll get into some more of the specifics in a sec, Brett, but what do you think about this?
Any discussion of monoclonal antibodies, any discussion of various pharmaceutical approaches to curing disease or treating disease or preventing disease always comes back to the wildly randomized, you try to go for randomized clinical trials, but it's more of a randomized like loyalty association that the right wing has with all of this. Like, pharmaceutical companies are bad, so we should take ivermectin. That's stupid. Ivermectin is made by a pharmaceutical company. We should go for monoclonal antibodies, but not really. That's just, they need to have a card that's like, I don't really mean this. It's just something I say in the meantime because I need to feel smarter than you. Yep. And then they call people who actually do their research and read up on stuff elitist. And then because they saw some random like Facebook meme with no serifs on it, they think that's them doing research.
Yeah. Well, look, I think a lot of people are going to greet this news if you even hear about it at all. And look, NPR did some good reporting on this. It's obviously not a thing that a lot of people are going to see, especially because like people don't necessarily want to acknowledge right now, as cases seem to be going down, that we might still have some issues, but we do, and we can't simply stick our head in the sand. What are some reasons for this? Well, there are a number of reasons why some of this medication might not be used. While the product is free, there may be administrative fees, so cost is a reason. The cost of infusion and injection administration is covered by Medicare and Medicaid, but not by some of the large commercial health insurance plans. So patients may be responsible for co-pays and deductibles, and all of that isn't necessarily super cheap. There is also, according to Dr. Amesh Adalja, there's a lack of awareness from patients and providers about how to use these appropriately. For instance, COVID pills must be given within 5 days of symptom onset and can be complicated to prescribe. Paxlovid can interfere with commonly taken medications, and there's other issues as well. So some people might not be able to afford it. Some people might not think that they actually have access to it. Some might, in theory, have access to it, but have problems with doctors prescribing it or prescribing it quickly enough, especially as our testing capacity continues to drop. People might only find out about the severity of their illness, take it seriously, and go to doctors at a point where it might already be too late for some of these treatments to actually help. And that is why, from floor to ceiling, we do still need to take this seriously, especially in terms of testing. We have way more capacity now to save people's lives and avoid costly, expensive, and dire hospital stays, but only if we understand the threat and identify it quickly. For more political news breakdowns, interviews, stories of activism, and me trying my hardest to care about the occasional big celebrity news story, subscribe to our YouTube channel at youtube.com/thedamagereport. And you can ring the bell wherever it is
so you don't miss anything.